The Vaccination Committee says 90% of Canadians over 50 could be offered their first dose of an mRNA vaccine by the middle of June. It's expected 75% of people between the ages of 18 and 49 will be offered their first dose by that point as well. Those calculations are based on the vaccine deliveries we're currently expecting in this country. Dr. Carolyn Quach-Thanh is the chair of the National Advisory Committee on Immunization. She joins us now. Hi, Dr. Quach-Thanh. Good to see you as always. I appreciate you making the time.
Hi, Vashi. You're welcome.
I know in all the recommendations and advice that your committee has provided so far, it's been in the context of supply. And so I'm wondering if supply does in fact end up ramping up, is the best advice to truncate that delay in doses?
Yeah, so we've always said that this 4 months was an up to 4-month interval, that whenever, the majority of your population already gets their first dose and you have enough supplies, then you move on to your second dose, hoping that this interval should, shrink to approximately 2 months to 2 months and a half fairly soon. I think also keeping in mind that all those decisions are basically implemented at the provincial level. So, people are asking questions to our committee and we're happy to answer. But in the end, the implementation is left to provinces because health is a provincial and territorial jurisdiction in Canada.
Yeah, and I can certainly delineate that for our viewers. Your committee provides the advice and the guidance, and then the provinces implement that. And we know, implement it to whatever they decide. And we know, for example, in BC, they implemented the delay in doses before your committee had even come up with that advice. Mm-hmm. When it does come to that, for example, moving to 2 to 2.5 months, is there a certain point at which, or a metric when you're looking at supply by which that move can be made, for example?
It's really when you have reached your population, right? So if you've already vaccinated 90% of your population with that first dose, then you should move on to your second dose. I think that what we have left in there is to give liberty to the provinces and territories to also maybe, focus on more at-risk groups. So for instance, in Ontario, there seems to be a decision to give that second dose earlier on to immunocompromised individuals, which is fine. But it's very hard at the Canadian level to shove a recommendation down everyone's throat because it is really dependent on your population and your epidemiology. Nova Scotia, for instance, where the number of cases have been low since the beginning, have this possibility to wait and vaccinate everybody, which might be different in other places. So what we've really said is first, for provinces where that second dose had already been, put on paper with a consent form, they were absolutely free to give that second dose within the delineated interval. And for other groups, for immunocompromised, for instance, or others, then provinces also have the freedom to make that interval shorter.
So I just want to dig into that for a second with you, because I think the last time we spoke, there had been the emergence of, I think it's called a preprint study in the UK. So in layman's terms that I would understand, that means it hasn't yet been peer reviewed. But it did show that there were some implications for people who are immunocompromised in delaying that second dose. And so I had wondered if, for example, NACI would come out with a more blanket recommendation around people who find themselves in that position. I gather from what you said that you didn't arrive at that conclusion, or what can you tell us about that?
So we did look at all those studies where really what we're looking at in there is the antibody response in either immunocompromised or elderly individuals. What those studies show is that immunocompromised and elderly people do not have an antibody response that is as high as a healthy younger person. However, the problem with all those studies is that there is no clear correlative protection. So we can't say that if you have a level of antibodies of X, you'll be protected. Some have very low level of antibodies and are protected because you have another type of immunity, which is cell-mediated immunity that can also protect you. And so not having that, it's hard to say, okay, so if you pass that bar, we were vaccinated. If you don't, we forget, or we know it doesn't work. What we do not know clearly with immunocompromised individuals is that even if you give 2 doses, we don't know how well they are protected because they were not part of the efficacy studies of all those clinical trials. And so our goal here is to be as equitable as possible, saying, there might be other groups in whom there were no studies done who are at increased risk of complications and who will not mount a good response to the vaccine. And so by trying to protect more people, we are then decreasing transmission in the community. And by doing so, we are also protecting those that are more vulnerable and who might not be able to respond well to the vaccine, either with 1 or 2 doses. So all that being said, it's possible that some provinces will still decide to go ahead with 2 doses at a shorter interval for immunocompromised and, let's say, elderly population, but might also decide to include other groups in there. It's just that when you're looking at it from the federal level, it's hard to say, okay, so you do this and you do that. We've just said that we left the freedom to those jurisdictions to decide.
Is it, and I hope this isn't a naive question, because I certainly don't have the level of expertise that you do, but is it safe to assume, even for those immunocompromised, that if you have 2 doses, you are more protected than 1, though?
It's possible, but we still don't know that. And in facing that, it's possible that somebody who is very immunosuppressed might not even be protected after 2 doses. So in that case, what we want is to have the lowest possible transmission in the community so that that person is also protected indirectly, because people around that person who have a good immune system are able to, protect, make that little shell and bubble around the most vulnerable. It's possible that with 2 doses, it's better than 1, but so those studies are ongoing. Whenever we have new evidence, we might change our mind. But it was really based on equity that the committee decided not to pinpoint specific groups to shorten their interval.
Beyond just more data becoming available, if in fact, again, supply becomes less of an issue, could that recommendation be augmented in the future?
Absolutely. I mean, what we've said in the recommendation is that, when you start giving that second dose, to start with those at highest risk of complications and death. And so that includes the elderly in long-term care facility, for instance. It includes the immunocompromised people. It also includes other groups such as Down syndromes and other neurological conditions. But that was clearly stated in the recommendation, so that when you start giving that second dose, start with those people.
Okay. All right, Dr. Quach-Thanh, I'll leave it there. Thank you very much for making the time tonight.
Thank you, Vashti. Have a good evening.
You as well. Dr. Carolyn Quach-Thanh is the chair of the National Advisory Committee on Immunization. Hi, I'm Vashti Capellos, host of Power in Politics. See more of our show by subscribing to the CBC News channel or click the link for another video.